change anything to what I just described, but we just prefer not doing that. So are you happy to participate on these conditions?
Yes, it's fine.
All right. So can you please tell me a little bit about your background, your current position, and for how long you've been in this role?
Okay. I'm board certified in oncology and hematology for 28 years. I've been at my present location for 12 years, and I work in a cancer center in a community. We have an academic center affiliation. I've seen mostly hematologic malignancies over the years, and I do some benign hematology, take care of a lot of leukemias, multiple myeloma, lymphomas, and work with about a half a dozen other physicians.
Okay. So you mentioned affiliation with an academic center. Do you also practice research or teaching?
I do teaching. I have fellows and residents, but I don't do anything other than clinical research, no bench type research or anything.
Okay, makes sense. And how many CML patients would you say that you see in a typical year?
Probably around 35.
Okay. And out of those 35, what percentage are new patients versus recurrent patients?
Probably around 25% are new.
25% are new. All right. And what's the split between chronic versus accelerated versus blast phase?
Well, as far as the 35 I'm watching now, I would say probably 25 are chronic, 5 maybe accelerated, 5 blast.
Okay. And do you manage any patient who have the T315I mutation?
We have 5, yes.
And what phase are they in?
2 and accelerated, 3 and chronic.
All right. Okay, so that's great. You see a very wide variety of CML patients. So you will see in the discussion we want to talk about mainly all the chronic accelerated, but we also have a specific interest in better understanding the T315I mutation. So the fact that you do see those patients is really great for this discussion. And what is the breakdown of the type of insurance coverage for all your patients, regardless of the disease?
I would say probably 40% Medicare, 40% indemnity type, probably the remaining 20% or what we call Medicaid.
Okay. And is the split different for CML patients specifically?
Probably not. I would say based on the age group of being around the average of 60, I would say no, it's probably the same mix.
Okay, so 60 would be Medicare.
Yeah.
Okay. And do you expect this insurance coverage, this mix, to change for CML patients in the future?
No, I don't think so.
Okay. And another question is, are the switches in patient coverage common in CML? Patient coming from commercial to Medicare, for example.
Yes, considering how long the disease duration of therapy and survival is, yes, there's quite often you'll see patients diagnosed in their 50s when they're on indemnity and go on to Medicare, yes.
Okay, all right. That sounds good. So I would like to talk a tiny bit about the epidemiology, so focusing on the current time in the US. So we've done secondary research and we've estimated the incidence and prevalence of CML in the US, and we'd like just to get your perspective on these numbers, whether they make sense, if you agree or not. So the first number is the total prevalent cases. We estimate that there are approximately 105,000 patients with the disease in 2019 in the US. So what do you think about this number?
Did you say 120,000?
105,000.
Oh, Well, I mean, I think that probably, I mean, I don't have any great criticism of it. I mean, I think that very well could be the number that would be appropriate. So, I mean, it's as good as I could come up with.
Okay. That sounds good. We've seen that these populations actually accumulating in the sense that people no longer die of CML. So because of the survival, that actually drives prevalence. And that's how we came up with this number. The second number I would like to get your perspective on is the number of diagnosed incident cases. So we estimate almost 9,000 newly diagnosed patients every year in the U.S.
Yes, I mean, it represents up to 20% of adult leukemia. So, and I think I've seen numbers around 5,000. It might be a little higher than I've seen, but due to the
okay.
I don't know. That's pretty close.
Yeah, it is. But okay, so 5,000 is actually a good estimate. We'll revise those numbers. All right. So you mentioned the split of your patient into the different phases of the disease, and I was wondering, in your perspective at the national level, what's the split between chronic versus accelerated versus blast?
Well, I would say 85% of the patients are probably in the chronic phase, and probably 15% are kind of split between accelerated and blast.
And would accelerated and blast, be evenly distributed, or would you expect to see one more than the other?
I'm not aware that there's any great difference between the two. I mean, they kind of ride on the fence of each other. If it's accelerated one day, it could be blast the next, so it kind of fluctuates fairly rapidly. So I don't think there's a big difference. Okay.
And when it comes to the T315I mutation, what's the proportion of patients, and we can segment between chronic versus more advanced, so proportion of patients who present with this mutation?
Did you say the T315I specifically?
Yes.
Or?
Yeah, specifically this mutation, yes.
I would say probably it's fairly rare. I would say maybe 5% maybe.
Of overall patients who may have that mutation?
Correct.
Okay. And what about those chronic patients who are intolerant or resistant to therapy?
Well, I would say at that point it probably goes up quite a bit. You're selecting out, so I guess it could probably go up to about 25% at that point.
Okay. And is this mutation more common in those accelerated and blast, given the increase in genetic instability in these patients?
Yeah, I would say so, because they're going to be the ones that are resistant to treatment. Yes.
And do you know what percentage of these advanced patients present with the T315I mutation?
I would say probably a third of them if they presented accelerated or blast.
Okay, all right. And the next question I have for you is, we could not find any number for the diagnosis rate. So in your perspective, what is the diagnosis rate currently for CML in the US?
Diagnosis rate?
Mm-hmm.
I just know there's about 5,000 new cases a year, with the median age being around 55 to 60. I don't know anything different than that. So
okay, that's fine. Probably more from a more qualitative perspective, given my assumption that physicians are well aware of the disease. It is rare, but physicians know about the disease. Maybe the diagnosis is relatively straightforward. Maybe the the patients who have the disease are mostly diagnosed, so diagnosis rate would be high. Do you agree with this statement?
Yeah, I mean, it's not likely that a person's going to live with it without being diagnosed. I mean, it's a fairly easy one to make the diagnosis of.
Okay, all right. And when it comes to treatment rate, are 100% of the patients diagnosed with CML receiving treatment?
Yes.
Okay. And are they typically compliant with therapy?
Yeah, I would say so. I mean, it's just like any other treatment that's oral based. I mean, you probably do have a lot of fall off, and I wouldn't say that they're 100% compliant. That might be, 75% or 100%, but there's a lot that are, and it almost adds up to 100%, but some, I mean, 25% are partially compliant.
Okay. All right. So I would like to talk about the presentation of the disease and the steps that you take to establish the diagnosis. So the first one is, could you describe to me basically the typical profile of a CML patient and rank the symptoms that they present with when there is a symptom actually?
Well, a lot of times patients just present feeling tired for various reasons. It could be from anemia. Unlike other myeloproliferative disorders, this one in particular can present with anemia in more than half the time, and white counts are greater than 100,000 often. I'd say, again, more than half the time. Platelets are also elevated and probably around a third of the time. And obviously, when you look at their peripheral blood, which physicians would be likely to do, they'll see that they see a full spectrum of myeloid differentiation in the peripheral blood, almost what we've always said. It looks like their peripheral blood is reflecting what goes on in the bone marrow. Mm-hmm. And then you can see in their differential things like the basophil or eosinophil count can increase. And of course, we have this suspicion that this is what's going on. We can do a FISH assay on the peripheral blood and get a Philadelphia chromosome positivity. And, once that we get that 922 translocation established, we got the diagnosis. But often we still do a bone marrow biopsy, and it shows hypercellularity and granulocytic hyperplasia, increased megakaryocytes with a hypolobulation, those kind of things, even an increase in blast. Okay. And, of course, clinically, we'll examine the patient. They won't have any lymph nodes, but they'll often have a splenomegaly, which they may have complained of some early satiety, and that's pretty much, in a nutshell, how a patient presents.
Okay, yeah, that makes total sense. So just to take a step back, the first step would be probably the general practitioner to do a blood test and see those abnormalities, right?
Yes.
And usually, how much time do these practitioners take before making the referral to you?
Pretty quick. I mean, they don't really have an idea that it's CML. There's nothing really standing out, but I would say within a week or two, they'll even be concerned that they might have acute leukemia. But I would say within a week or two from the time they see a generalist or emergency room that come in with this complaint and finding that they're seen by the hematologist, oncologist, and the diagnosis is confirmed.
Okay, that makes sense. And so then you receive these patients, you do the FISH on the blood that establishes the CML diagnosis, and you go to look at the bone marrow. I imagine the bone marrow is not just to confirm the diagnosis; it also helps you establish the staging of the disease.
Well, yeah, I mean, there really isn't much as far as there is a phase of disease. I don't really think there's an official staging system. I mean, CML is like you either treat it or you treat it. There's no in between. Like CLL has a variety of stages. CML, basically, we have chronic and versus accelerated and versus blast crisis. Mm-hmm. And of course, that's all based on things like the percentage of blast, basophilia, platelet counts, increasing splenomegaly and white blood count issues. And we don't see very often. Most patients present with chronic phase. So, if they have 20% blast in the bone marrow, we automatically call them acute blast crisis.
Okay.
So, it really isn't any official staging.
Yeah, okay. Yeah, and especially for the accelerated phase, I saw that there are many different classifications, notably one from the WHO. So I was wondering, do you refer to one of these classifications when establishing the diagnosis?
That was what I kind of mentioned was roughly the WHO classification, where you at least have one of the features of 10 to 19% blast. I think it would be, because it's not 20 in the peripheral blood or bone marrow, and basophilia of greater than 20%, or platelet counts less than 100,000, or platelets greater than 1 million, and then progressive splenomegaly, or increased white count that's not responding to standard treatment, or cytogenetic evidence of clonal evolution.
Okay. And when it comes to the chronic patients, do you subsegment them into low risk versus high risk?
I don't really know. I guess you could say that if a patient was in chronic phase and had an adverse cytogenetic abnormality, that they might have might be a little bit more high risk. I'm not really stratifying my patients if they don't meet the criteria for accelerated or blast crisis in that chronic phase.
Okay, and you don't face any pressure from, I'm thinking more payers to actually...
Oh, I think I know what you're saying now, like the Sokal score or something, like low versus intermediate or high. Yeah. Sometimes I do when I'm deciding whether to use a second generation or first generation, like imatinib. I might, if they have a low Sokal score based on, the percent blast or platelet count or spleen size or age or things like that.
All right. So you would actually look at those at the Sokal score, but not necessarily call it a Sokal score, and determine whether to use imatinib or second gen. And after that, depending on, I imagine, the type of insurance, you may have to establish the formal score. Would that be required by some payers?
Yeah, if they wanted me to justify not using imatinib, a lot of it, since it's went generic, I might have to come up with a Sokal score based on those parameters, low, intermediate, or high. And if it doesn't fall in the low, I can maybe make an argument for using a higher level treatment, such as second generation TKIs. Okay,
that makes sense. And at what time do you even look at the mutational, do a mutational analysis on the BCR-ABL1? And for which patients do you look at that?
I don't routinely do mutational analysis unless the patient's refractory to therapy. Okay. I do obviously monitor things like the PCR, quantitative PCR. Okay. Initially, I monitor the cytogenetics by FISH just to make sure that's cleared out for a good cytogenetic remission, and then I go on for molecular remission monitoring by PCR. But I don't do any clonal evolutionary studies that would necessarily require bone marrows on a regular basis, and I'm not particularly keen about doing that.
So definitely any patient who becomes refractory, you would do that. And what about those advanced patients? Do you look at what mutations they might have at the time of diagnosis, so the accelerated and blast?
Yes, at that time when I do a bone marrow, I will, and obviously I have the bone marrow and the ability to do that, but like I said, I don't do it again unless I start seeing that they're refractory to first or second generation treatments.
Okay. Okay. So, and that would be basically across all phases then. All right.
Yes.
Okay. Um, and my next question, I think I'm sorry, just a second. I'm checking my notes, and
Okay.
yes, we've covered everything. So the next part is really, I would like to understand, your approach to therapy, and how it is or it is not different between the chronic versus accelerated and blast patients. So just a high level, can you please explain to me how you treat these patients?
Well, basically, what I start with is based on the SOCO score. Like I mentioned, if they're low, I might make a point for imatinib. It's cheap.
Mm-hmm.
If not, they're intermediate or high, I tend to go a second generation at least. Of course, recently, not too long ago, I'd say a year or two, belsutinib got approved as
Mm-hmm.
can be used as a frontline treatment, just like the other second generations. Dasatinib and nilotinib.
Mm-hmm.
I tend to choose one over the other just simply based on the toxicity profile. There's some issues with dasatinib. It might be something that's easier for patients to take. It's a once-a-day treatment. I think it's not
Mm-hmm.
affected by food, whereas nilotinib might have a longer data follow-up, and also has the indication to stop if they have a persistent major molecular response, and they may want to do that, and I might have nilotinib. So it just has a lot to do with their toxicity profile and
Okay.
the background drug. And if a patient has a history of diabetes or pancreatitis, I might want to avoid nilotinib, avoid dasatinib if they have history of COPD, heart failure, or hypertension.
Okay. And do you follow the same algorithm? I would say, do you start on the same second generation drugs for the accelerated and blast phases as well?
Yes, I mean, if they start to show evidence of acceleration, I have to do a bone marrow, show any type of new clonal changes. If they have something like T315I, of course, all we have is ponatinib,
Mm-hmm.
inclusive, and then we start looking at donor situations because there it might be advantageous to get them outlined for stem cell transplant with an allo transplant.
Okay. And what percentage of your AP patients would you say ultimately receive the transplantation?
What percentage are going to receive what? I'm sorry.
The transplantation.
Oh, well, I mean, I would say as far as the ones that accelerate or go into blast crisis, I would say maybe, at least 75% go on to some form of a stem cell transplant.
Oh, wow, that's a lot.
Yeah.
Okay. And how long does this take for these patients to go through the transplantation after the diagnosis of AP? Does it take a couple of years? Is it a few months? I'm just trying to get a idea.
I would say probably around average of 6 to 8 months.
Okay, so it's pretty fast. Okay.
Yeah.
All right. And so going back to so that's how you treat the first line, and then for the second line. So do you switch from a second gen to another second gen? How do you make the decision?
Well, yeah, I consider increasing. Changing to a different one. I think in the past we used to increase the dose of imatinib to 800 milligrams up to that. But I mostly switched to a different TKI to see if we can't. Of course, there are some evidence that certain mutations might be more responsive to one than the other, and of course the T315I for sure to ponatinib. So yeah, we do switching issues to try to buy a little time when they do progress and show evidence of acceleration. And then, of course, like I said, we plan on a transplant.
Okay. And do you use also the omastataxin?
Oh, yeah, Cinrabo. Yes, I didn't mention that. Yeah, we occasionally use that in these patients that are progressing. I know there's been some interest even adding it early on to patients to see if you can get a major molecular response and can stop treatment. But we have used that in accelerated and blast crisis to kind of buy us some time. It's not what I'd consider a long-term thing, but it does seem to be fairly effective in that situation.
Okay. And what about the chronic phase? Do you also use this drug?
No, not really in the chronic phase so much. We don't use Cinrybo, no.
Okay. All right. And so how efficacious, do you consider these therapies overall?
Well, I think it's probably the most successful biologic lock and key, I guess, almost approach to treatment of malignancy that we've ever seen.
Mm-hmm.
Rarely can we intervene with one mutation like this to have such a profound effect on the natural history of a disease as we have in CML. So there's no doubt it's a disease meant for biologic therapies based on its profound driver mutation.
Mm-hmm. Yeah, absolutely. So that BCR-ABL1 is actually the main driver, if not the only driver of tumorigenesis in these patients.
That's correct, but 85% seem to do well, and it's one of those rare situations where the longer they're on treatment, the longer they're likely to stay on treatment. In other words, the patients can depend on being on this for a long period of time. I guess the only thing I'm concerned about now, maybe we should reconsider trying to get patients off therapy if we can, if they have a major molecular response, because I think we're starting to see issues with people on the drugs for 20 to 30 years now, and starting to have maybe cardiovascular issues, maybe even neurologic from being on long-term TKIs.
Okay. So actually that leads me to my next question, which is, in your opinion, what are the unmet needs for the management of CML?
Well, I think coming up with a better determination and more definite recommendation about discontinuation of the TKIs. I think much to the chagrin of the pharmaceutical companies, I think that they're not particularly interested in not, continuing therapy, but I think that's something we have to be cognizant of, that it's appropriate.
Mm-hmm. Okay. Yeah. That's absolutely fair. And then in terms of, the availability of options, are you satisfied with the current number of options that you have, or would you expect to see more or different?
I'm pretty satisfied with the options that we have. I think we have a lot of options. Sometimes it seems like we have more options than we have patients in this particular disease type.
Mm-hmm. Okay. So you're pretty satisfied. And does this apply to both the chronic and the more advanced patients alike?
Yes.
Okay.
Well, not the advanced patients. I think we can always use more options in that situation.
Okay. And because we have this, specific interest in this T315I mutation, so I know there is ponatinib, which is a available option. So how satisfied are you with ponatinib for this specific patient cohort?
I'm sorry, which ones?
The ponatinib for the T315I mutated patients. Are you satisfied?
Yeah. Well, I think it's pretty good. We've had some issues with problems about, cardiac issues. There was that situation where there was a brief removal of this from the market.
Mm-hmm.
And I think that was possibly a lot to do with dosing issues.
Okay, so now you would consider ponatinib to be pretty efficacious. And what about the safety, besides the cardiovascular issues?
Well, I mean, I think for the most part, I don't know of any major problems I've had. I think the cardiac one was the main one, and like I said, I think that the reducing the dose of it,
Okay.
Was very helpful in that regard.
Okay.
I think that as far as having black box warnings, I mean, there's other issues, as far as liver issues that we have to be concerned about that would also be nice not to have to deal with. There's even not just arterial, but venous and cardiac failure. So, I mean, it does have a fairly, I guess just because we haven't had any other choices in this situation other than maybe Cinrybo, we've pretty much accepted these side effects.
Okay.
But it would be nice to get rid of some of these black box issues.
Okay. I know it's not been on the market for very long, but do you see some patients becoming refractory to ponatinib?
Well, I mean, yeah, I think it can happen. I mean, I've used it also in other situations. It seems to be one of the better ones for ALL. That's Philadelphia chromosome positive, but definitely resistance can develop. Yes.
Okay. Okay. And if you think about the pipeline and the potential future treatments, do you expect any change in the treatment for CML, let's say in the next 10 years?
Well, I don't know. I mean, I've seen other drugs being looked at as far as TKIs. I guess we're now just kind of thinking that we got enough of them, but I'm sure others will come along that will give us more tools in the toolbox, I guess, to manage the situation. But I think the thing we're looking for is ways of getting a major molecular response that might allow us to stop treatment. Like I mentioned, there was this interest in possibly combining Cinrybo with TKIs to affect that so we can stop treatment in more patients.
Okay. And if you were to combine the TKI with Cinrybo, what are the advantages or disadvantages? I'm not really thinking about the side effects. So I'd like to get your perspective on the pros and cons of this type of combination.
Well, I mean, anytime you combine drugs, I mean, you're going to have to accept more side effects. And I think that I haven't really done that routinely as far as combining Cinrybo with other drugs. So I don't know how that would work out. I know there's no black box warning or anything with Cinrybo. The main adverse issues I've dealt with is just cytopenias. There's a little bit GI toxicity associated with it. I think it would be fairly easy to do that. I guess you might have some issues with drugs that affected the liver because there is some liver effects from Cinrybo. So I imagine that combination like Cinrybo and ponatinib might be kind of on a difficult situation.
Okay. Yeah, and like you mentioned, there are many drugs actually currently in development for the management of CML. There are a lot of new TKIs, and there are other drugs with totally different mechanisms of action. So first question, is there any drug currently in development that you're aware of and think has the most potential to bring value to these patients?
No, I mean, I guess I've looked at your profile on this skiminitinib, so I don't. I mean, I have to admit, I don't know if I heard about a drug previously, and that might have been it, and that would be it. Okay.
And then, pure conceptually speaking, so there are drugs that are beyond the TKI that, for example, that JAK inhibitors, there are PD-1s, etc. Are there particular mechanisms of action that you think have more potential to bring value, and if not as a standalone, at least in combination with the TKI?
Well, no, I don't think anything will replace a TKI for sure because of its, like we mentioned earlier, the very potent driver mutation, and therefore I'm also thinking that there's not likely a lot of advantage to combining it with something else because that is a very potent driver of the disease process. I guess it only remains to be seen whether you can improve it a little bit, and I think the little bit is going to be able to stop the treatment.
Okay. Yeah. And so if I guess my next question it goes back to PD-1. PD-1 really tries to harness the immune system to attack the tumor cells. So do you think this one would be therefore more interesting compared to other kinase inhibitors like JAK, etc.? To combine with the TKI?
I don't know.
That's the assumption.
I'm a little skeptical. I mean, I know the PD-1s, I've used them in other areas, especially like Hodgkin's disease. I'm not sure of the upregulation of anything such as PD-L1 with CML or even tumor mutational burden. I wouldn't think it is. It seems to be a single mutation in most patients. So I'm really skeptical that the immuno-oncology approach is likely to be that effective in this disease. Okay.
All right. That's a very important consideration. Thank you very much. I think now we can move to the target product profiles. So we provided 3 different profiles. The first one is asciminib, like you mentioned, which is a drug from Novartis. The second on slide 3 is going to be product X, which is the drug we're the most interested in. And then on slide 4, you're already very well aware, but we just provided the clinical trial results for ponatinib, just in case for the respondents who are not fully aware of those data. And finally, on slide 5 and 6, those are just the exact same information, just a side-by-side comparison. That's it. So I would like to start with slide number 2 and get your overall feedback on asciminib. And if you need to take a minute to review the data, I can wait.
Okay, I'm looking at it right now. I mean, it looks pretty well tolerated as far as this combination therapy. And obviously it's more effective in the non-ponatinib resistance. And I mean, I think overall it looks like it might give a little bit of an edge to patients that are intolerant or resistant. I mean, I don't think it's likely to, change things a lot in the treatment armamentarium. I mean, I think that it's just a little bit better than these drugs are by themselves.
Okay. And so if you have to, just select the top 3 positives about this drug, which would those be?
Did you say adjectives or?
Oh, the positives, the pros and cons of that drug.
The top 3 pros, I guess it's fairly well tolerated. It can be combined with other drugs without much difficulties. And I guess it gives another option in patients that are not tolerating standard care therapy. I guess cons, it doesn't seem to work that well in ponatinib resistant patients. it necessitates using two drugs, and I guess probably that's it.
Okay. And if the drug is actually, if it were approved for as a monotherapy for the management of the chronic patients, I think they are trying to receive approval for third line in this chronic only, who are T315I negative. What would be your perspective on, or your opinion on this drug for these specific patients?
In chronic patients?
Yes, chronic patients intolerant or resistant to two TKIs.
Now, it shows here they're using it with a TKI.
Yeah, that's what they're going after. Actually, based on those data, they decided to move to a phase 3. So it's currently in phase 3 as a monotherapy for chronic patients who do not have the T315I mutations. It's kind of confusing.
Okay, but yeah, I mean, in that situation, I mean, I guess it would just be another option. I guess it would be, another option to have. I don't think there's any single agent data in this slide too, is there?
No, that's correct. Unfortunately, it's only in the T315I positive.
I mean, I would imagine it is probably as effective. I mean, I think they're all pretty much similar in their efficacy, maybe, a little bit better than imatinib.
Okay. And so if you had to rate this drug on a scale from 1 to 5, 1 being low and 5 being high, what score would you give this drug?
Maybe a 3.
A 3. And can I ask why exactly?
Well, I mean, I think there is some advantages that I mentioned that can help, but I mean, I think at the end of the day, if you're using it as a single agent, it's just another drug like nilotinib or dasatinib or bosutinib.
Mm-hmm.
I don't think it's really adding that much. It's just another drug.
Okay. And that's totally fair. Do you have a different opinion when it comes to the accelerated phase patients? You mentioned a higher level of unmet need for these patients. So do you think this drug, let's assume as a monotherapy, that as a monotherapy, this drug would be a good additional tool?
Well, I think in an accelerated phase, there might be a better reason to use the drug because, I mean, we don't have a lot in that area other than Cinrybo, ponatinib if it's due to T315I. So, I mean, I guess in that area, we always have a little bit more need and it might serve a little bit more purpose.
Okay. And the last segment, which is this combination with imatinib. So at the moment, they decided to develop the drug in combination with imatinib for those patients currently receiving imatinib, however, not achieving a deep molecular response. So for that specific utilization, what's your perspective? What do you think about this one?
Well, I think it's okay, but what we've typically done in that situation is just switch to a different agent, not really add something to it. And I can always imagine if you're adding two drugs together, you may or may not get more toxicity, but it certainly will increase the expense. So, I mean, I don't understand why you wouldn't just go to a different generation. Bosutinib, nilotinib, or dasatinib would be probably the best thing to do than just add a drug to it.
Okay. And when you look at the efficacy of this combination, we don't have the side-by-side comparison with nilotinib alone or dasatinib alone. But in your experience, how does this efficacy for this combo compare to your experience with the other lines of therapy, with the other drugs?
Well, I think it's pretty consistent. I don't think there's much difference or surprise.
Okay. That's actually all the questions I had for asciminib. So in the 10 minutes that we have left, I would like to talk about product X. So I can give you a couple of minutes to review and then I will basically ask the exact same questions.
Okay. Okay.
Okay, so overall, what's your impression on this drug?
Well, I mean, it seems to be very efficacious in patients that are intolerant or resistant to other TKIs. And I mean, I think being able to possibly even stop treatment after being resistant to others and up to, maybe 15%. And I know it probably was just the fact that there was a smaller number of patients, but they're still even holding that up in T315I population. I think that they certainly didn't go down any, if anything, a little bit higher. I think it looks like it's a good drug to use in patients that are refractory or intolerant to other treatments, and very respectable outcomes in that chronic phase, accelerated phase. Even in that population, almost a third or major molecular response or major cytogenetic response, So, I mean, I think it looks very efficacious. The toxicity profile looks good. Most of the severe stuff looks hematologic, not really any of them leading to discontinuation. So, I mean, it looks like a very good salvage treatment to me.
Okay, that's great to hear. So what would be the top 3 positives and top 3 negatives or concerns you might have about that drug?
Well, I guess efficacy as far as resistant patients or intolerant of other TKIs in chronic phase, efficacy in accelerated patients, toxicity, discontinuation rate very low. I guess negatives, no frontline data to look at this point. No known issues about combination therapy with it, and I guess no data regarding the ability to stop it after obtaining a major molecular response.
Okay. After molecular response. Okay. And what about the dosing? This one is a once every other day, which is different from the other TKIs. Would that be a concern to you?
Well, yeah, that's a tough one because I'd almost wish they could come up with something like every Monday, Wednesday, Friday, or take it every day but Monday, Wednesday, Friday, because when you start doing something every other day, you really have to have a calendar, or elderly patients especially. They'll forget, did they take it the day before or not? So I'm a little leery of that. I try to avoid telling patients to do something every other day because they'll lose track of it and they'll either over or underdose themselves.
Okay. That's actually what I expected as feedback. So overall, on the scale from 1 to 5, what score would you give this drug?
I guess probably a 4.
Okay, so slightly better than the asciminib therapy.
Yes.
Okay. And if the drug was approved, so where would you see it positioned on the guidelines?
Well, I think it would probably be positioned kind of like what bosutinib was until it got frontline indication.
Okay. So we'd start third line potentially and maybe reach second. Do you think this one could reach first line?
Yeah, I mean, a betting person would say any of these drugs that's salvaged from another one would be able to go frontline, just like bosutinib did.
Mm-hmm. Okay. And so, in what percentage of your patients would you potentially use this drug? And we can segment by cohort. So, for example, in the chronic or resistant or intolerant, in what percentage of these patients do you think you may use this therapy?
Oh, right now, probably 100%.
Really? So that would be so we're talking third line, right?
Yes.
Okay, and you would use that instead of the other second generation that are here. Right now, when I'm considering the third line, I'm excluding the T315I. I think that's a separate category.
Yes, I'd still say 100%.
Okay. And if it were in second line, what percentage of your patients do you think may receive this therapy?
Oh, I would say probably 50%.
Okay. And the T315I, how does this drug compare to ponatinib?
Oh, I'd say it does slightly better and for sure better in toxicity. So, I mean, my T315I, I'd say 100% would get this.
Okay. All right. And in your accelerated patients, regardless of the T315I mutation, would you use this drug?
Sure. Accelerated patients, I would use it in 100%.
Okay, those are very high prescription rates, but I'll take that.
Yeah, I mean, I think it's very good. I mean, I look at the toxicity, it's mostly hematologic based on what I'm interpreting, and I don't have much problem with that, and I don't see any black box warnings or issues. So I think I would say it would be a very successful.
Okay. Would you expect any challenge for this drug to receive FDA approval or potentially reimbursement? Anything at all that would come to your mind?
Not based on the statistics, because I don't think we did it, but I looked at the ponatinib stuff, and it compares quite well with that. And especially since you're losing some of the black box warning issues, or you're losing them all, I don't think there would be any issues at all.
Okay. All right. So I think those were absolutely all the questions that I had for you today. No, one more. I know you rated it 4 out of 5, so there's still some room for improvement. You mentioned some data that are currently missing that you would like to see added. Is there anything else that the company can do to actually improve your rating or improve the value of this drug?
Just make sure they come up with something other than every other day dosing, if they could. That's very difficult for some of the elderly patients to remember.
Okay. Anything else?
No, I think other than that, it's pretty good, favorable. Nothing really I can criticize.
Okay, well, thank you very much for your time. That was a very positive discussions. I know I didn't really comment much on your responses, but I really enjoyed our conversation, and this was very